Good morning, everybody. We had an outstanding walk this morning. We had an all-time record number of participants. I think we must have had 50 people out there, and last year it was 25. So maybe even more next year. We'll see. So thank you all for being here.
One dog.
And one dog, Kelly's dog Daisy, greatly enjoys the walk. So here's my disclosure. And these are my objectives. I'm going to talk about the rationale for treat to target, some recommendations from a task force, and some clinical applications. I'm going to give you the history of treat to target. I think most of you have probably heard of treat to target. And the reason that we do this is that there's a lot of different choices for osteoporosis medications. They're divided into these two categories that you're very familiar with, those that primarily inhibit bone resorption, those that stimulate bone formation. But there's a big challenge on which one to use, when to use it, how to use it, when to change, what sequence of drugs is best. So what seems like a simple decision on the surface turns out to be fairly complicated. Now, insurance companies have a very easy answer for us. You're all familiar with this. Fail first. This is where we're required to start off with the cheapest medication. That's usually a generic oral bisphosphonate. If that can't be used, then we go to an IV bisphosphonate. If that doesn't work, then maybe denosumab. And if we're really, really lucky, if that doesn't work, we might get to an anabolic agent. But there are tremendous hurdles for doing this. It may not be in the formulary. If it's approved, the copay may be high. So for this reasons, we and our office staff have to spend a lot of time on prior authorizations and appeals, which is no fun for anybody. So some of the limitations of step therapy are that it does not allow for individualizing treatment decisions, especially with initial therapy. And step therapy is not supported by new data and clinical practice guidelines that we're now using. Treat to target goes by a number of different terms. Sometimes it's called goal-directed treatment, treat to goal. It's got a whole lot of acronyms that go with it. But it's a familiar concept, I think, for endocrinologists, rheumatologists, cardiologists, and others for a broad range of disease states, as you see here. So I'm going to give you a brief history of treat to target in the world of osteoporosis. So there were two publications, both in March of 2013, so we're talking 11 years ago, that came out within days of each other in different journals with overlapping authors. And for the first time, the concept of treat to target was presented to the medical world in a formal sort of way. And to summarize what these papers said, the idea was that before starting osteoporosis treatment, patients should have fracture risk assessment, including vertebral imaging when indicated. So this is going beyond a reflex action of starting alendronate as soon as a diagnosis is made. They went on to say that initial treatment should be with a drug that's most likely to achieve an acceptable level of fracture risk, that patients should be monitored for response to therapy, which is all that we used to do, and also to see if they're on a pathway to achieving an acceptable level of fracture risk. So it used to be that if a patient responded to therapy, we were happy. We patted the patient on the back and said, good work, keep on doing what you're doing. That would be a little bit like starting antihypertensive medication and getting the systolic pressure down from 220 to 190. They've responded to therapy. You don't tell the patient you're doing great and send them on their way. You do more. And maybe we should be doing the same with osteoporosis. Treatment should be modified when attaining a treatment target appears to be unlikely. And both of these publications recommended that a task force be formed to explore the possibility of developing treatment targets for osteoporosis. And a task force was formed. And the task force published a report about 4 years later. And this was a task force composed of people in ASBMR and NOF, now called BHOF. And the task force reiterated this concept that initial treatment should be selected according to the likelihood of achieving an acceptable level of fracture risk over a reasonable amount of time. And again, they said a patient may respond to therapy, yet still have an unacceptably high risk. Response to therapy is essential, but not necessarily sufficient in achieving an acceptable level of risk. And I put this in quotation marks, and that is that it was stated that these preliminary principles should be revisited when relevant new data and analyses become available and when new treatments with substantially greater effects on BMD and fracture risk are approved. And indeed, all of that has happened since the time of that publication. So in the initial report, a variety of treatment targets were considered. One was a fracture risk algorithm, something like FRAX. In fact, the concept of this even had a name. It was called TRAX, T-R-A-X. That would represent something like FRAX that created an estimation of fracture risk that changed according to the treatment that was started. But there is no TRAX, and so far no algorithm has been developed that can accurately estimate the change in fracture risk associated with treatment. The other target that was considered is bone turnover markers. Some of us love bone turnover markers, some never use them. We like to see them change in the appropriate direction when we start somebody on a medication. But there's a lot of different bone turnover markers. Sometimes the reference values are not well standardized. It's not clear which bone turnover marker is best for which drug, and it just turned out to be too complicated. So what we were left with was bone mineral density as what seemed to be the best treatment target. So a lot has happened since that report in 2017. And let me just go through some of the things. Since that paper was written, we've had the approval of 2 new anabolic agents, abaloparatide and romosozumab. Teriparatide in the brand name form, Forteo, is now approved for longer than 24 months lifetime. We have comparative effectiveness studies, so we now have pretty good data showing that some drugs are better than other drugs, and we hadn't really shown that before. We have head-to-head studies showing superiority of anabolic agents compared with bisphosphonates for fracture risk reduction. We have real-world evidence that some antiresorptive agents reduce fracture risk more than others, and for one anabolic agent, we know from real-world evidence that it reduces fracture risk more than another. We have the FNIH SABRE meta-regression study of over 50 randomized controlled trials showing a strong correlation between increases of BMD with treatment and subsequent reduction of fracture risk. And there's more. Recent guidelines have established a new risk category called very high fracture risk that didn't exist before. This has implications for selecting initial therapy. There's recognition of the importance of treatment sequence, that anabolic before antiresorptive is preferred in high-risk patients. We have an appreciation of imminent fracture risk, that there is a very high fracture risk in the first 1 to 2 years after a fracture, creating an urgency to evaluate these patients and initiate treatment rapidly. And we have data supporting a specific BMD target. So that's a lot that has happened. So I'm going to go through some of the data with regard to the things I've just mentioned. This is from a population study in Iceland showing that the risk of a second major osteoporotic fracture is very high in the first 2 years after an index fracture and remains higher than those without a previous fracture. So the dashed line at the bottom represents the risk in people who have never had a fracture. The top line represents people who have had an index fracture. And the Swiss Association Against Osteoporosis has actually come up with a more formalized definition of imminent fracture risk, and they're calling it greater than 10% risk of fracture in the next 2 years. So different sorts of way of thinking about the same concept. Now, very important is recognition of differences among drugs, and that some might be better than others. So we have at least 4 randomized controlled clinical trials showing superiority of anabolic agents for reducing vertebral fracture risk compared to bisphosphonates, 1 with glucocorticoid-induced osteoporosis, and 3 others in patients with severe postmenopausal osteoporosis. So what I usually tell our fellows when we're talking about choices of treatment is that any treatment is better than none, but some treatments are better than others. The real problem, of course, is that most patients who could benefit from treatment don't receive any treatment at all. So it's never a mistake to start with the basic generic alendronate if you want, but it may be far better in high-risk patients to start with more aggressive therapy, such as an anabolic agent. Here's some of the real-world evidence. These data were initially presented at the IOF meeting last year and recently published in JBMR, showing that denosumab reduces fracture risk more than alendronate. So this is a retrospective cohort study of Medicare claims data in the US with almost 500,000 women on Medicare. And it showed that denosumab reduced fracture risk at all of these different sites: major osteoporotic fracture, hip, non-vertebral, and non-vertebral excluding hip. So this is an observational study. It's not the same high level of evidence as a randomized controlled trial, but nevertheless, despite all the limitations, it's a very large number of patients, and it does support what makes sense to us all anyway. If we have a drug that increases bone density more, we would expect that it would reduce fracture risk more. We also have real-world evidence that denosumab reduces fracture risk more than zoledronic acid. And again, this makes sense since we know that denosumab will increase bone density more than zoledronic acid. More real-world evidence. This was presented this year at the IOF meeting in London, showing comparative effectiveness of abaloparatide versus teriparatide. And here we see that the evidence in this study shows a greater reduction in fracture risk with abaloparatide. So I think unlike health plans or some people who may think that all osteoporosis drugs are pretty much the same, there are not only differences in mechanism of action, but there are differences in their efficacy. We've also come to appreciate the importance of sequence of therapy, and that anabolic therapy first in high-risk patients will generate a greater response than the reverse order. Felicia Cosman has done a great deal to bring this to our attention, and she has a nice review paper here published 7 years ago now, looking at what happens with teriparatide after an antiresorptive agent. And all of these studies have shown that there's a transient or sustained bone loss at the hip with antiresorptive followed by teriparatide, especially a concern when denosumab is followed by teriparatide. So based on the limited data we have, that's probably not a good sequence to go from denosumab to teriparatide. We know that the reverse is true, that BMD gains are greater when anabolic is given before antiresorptive. And this is the case here, looking at both the total hip and lumbar spine. Here we have a review of data in 4 randomized controlled trials, looking at romosozumab given before an antiresorptive or after an antiresorptive. And it's very clear that in the ARCH and FRAME studies, giving romosozumab first results in a greater increase in bone density than the reverse order. And this is the case whether we're looking at bone density at the total hip or the lumbar spine. This has sometimes been called the foundation effect, and it illustrates very clearly the importance of a sequence that involves romosozumab followed by denosumab. So the left-hand curve shows what happens to bone density with 1 year of romosozumab followed by 1 year of denosumab. You see quite a rapid and large increase in bone density. The other line shows what happens to bone density with 10 years of continuous treatment with denosumab. Denosumab gives a far greater increase in bone density than any of the bisphosphonates. And with the sequence of anabolic followed by antiresorptive, we can achieve in 2 years what it would take to achieve in about 7 years with denosumab alone. So if you have a patient at very high risk for fracture and you believe it's important to increase bone density as greatly and as rapidly as possible, then this sequence of anabolic followed by antiresorptive might be attractive to you. More on comparative effectiveness. Well, what about bone density? This is kind of an unfair comparison. You've already seen this slide before at this meeting, but it very clearly at least shows a difference in pattern with 2 bisphosphonates, alendronate and zoledronic acid compared to denosumab. So when we give any bisphosphonate, we can expect an increase in bone density over the first several years, followed by a plateau of bone density, and probably no additional benefit in terms of fracture risk reduction. Whereas with denosumab, bone density continues to rise at least up to 10 years. And there is some evidence suggesting that fracture risk continues to be low, and perhaps with non-vertebral fracture risk gets even lower with long-term treatment. Looking at bone density with anabolic drugs, again, there are differences. Now, I have to say this is an unfair comparison, putting romosozumab in here because it's a different study, but teriparatide and abaloparatide were studied head-to-head in the active study with the lead author of Paul Miller, and there was a somewhat greater increase in bone density with abaloparatide compared to teriparatide. And in a different study, the FRAME study, we see a far greater increase in bone density with romosozumab. Here is the structure study with Bente Langdahl being the lead author. And this looks at a real-world common scenario that we have with patients on bisphosphonates, sometimes for many years, who then are transitioned to an anabolic agent. So we have to wonder, will anabolic agents still work after long-term antiresorptive therapy? And are there differences in the response to anabolic therapy? So these are patients who are on bisphosphonates in most recent years with alendronate, and they were transitioned to either romosozumab or teriparatide. And we see distinct differences at the total hip. There's an increase in bone density with romosozumab, whereas a slight decrease with teriparatide. Cortical bone density by QCT, went down with teriparatide. There's differences in integral BMD with QCT. And finite element analysis, which is an estimate of bone strength, increases with romosozumab and is stable or goes down a little bit with teriparatide. So again, differences in which drug we choose. So what about the relationship between BMD changes with treatment and fracture risk? Well, we have some interesting data. You've seen a version of this study before. This is looking at total hip T-score and non-vertebral fracture risk with denosumab. And we can see that the reduction in fracture risk seems to plateau around the total hip T-score of minus 1.5. So if we're trying to treat to get optimal fracture risk reduction, perhaps getting to a target of around minus 1.5 is a reasonable thing to do. And maybe there's not a whole lot of additional benefit to try to push the bone density much higher than minus 1.5. Also, it was shown that when baseline T-score was between minus 2.5 and minus 2.0, that a T-score increase of at least one T-score unit was associated with a significant reduction in non-vertebral fracture risk. So the data here accumulated by Felicia Cosman shows greater reduction of fracture risk with larger increases in bone density in the ARCH study with romosozumab versus alendronate. The 12-month data shows the best correlation was between total hip BMD increases with romosozumab or alendronate and fracture risk reduction. And again, we see here optimal fracture risk reduction at about a T-score of minus 1.5, again suggesting perhaps minus 1.5 might be a target to consider. The lumbar spine BMD increase with treatment in these studies did not predict non-vertebral fracture risk reduction. So if you're choosing a skeletal site to monitor and to use as a treatment target, this suggests that the hip might be better than the spine. So a lot of you have heard of the FNIH SABRE project. The origin of this goes back to 2012. This is called the Study to Advance Bone Mineral Density as a Regulatory Endpoint. 4 years later, in 2016, the U.S. 21st Century Cures Act was created, aimed at accelerating medical product development by allowing surrogate endpoints to replace direct measures for clinical endpoints. So what are the endpoints in osteoporosis registration trials? Well, it's vertebral fractures. What if we had a surrogate endpoint that would allow us to have shorter, less expensive studies? Perhaps we'd have more drugs in development. In 2020, there was publication of a meta-regression study with patient-level data in over 150,000 participants with approved drugs. A qualification plan in 2022 was accepted by the FDA. And in January of this year, what was called a full qualification plan was submitted to the FDA with a proposal to accept total hip BMD increase of 1.42% compared with placebo over 24 months as a surrogate threshold effect for reduction in fracture risk. So imagine if we could do a 2-year study showing that kind of BMD increase and have a drug approved with a much less expensive study with a smaller number of subjects. That might open up the pipeline for drug development, which is now totally shut down. So Mary Buxheim, Dennis Black, and colleagues published this in 2019. So this was a meta-regression study showing that greater improvements in BMD were strongly associated with greater reductions in vertebral and hip fractures. And the implications for this were that improvements in BMD with osteoporosis therapies might be useful for a surrogate endpoint in clinical trials, and this provided supporting evidence for the concept of treat to target. And these are the kind of graphs that were published with these studies that regardless of whether you're looking at total hip BMD, femoral neck BMD, or lumbar spine BMD, the greater the increases in BMD, the greater the reduction in fracture risk. This is for vertebral fractures here. You see the list at the bottom of all the different drugs that were included in these clinical trials. And the size of the little circles represents the size of the trial. Same relationship holds up looking at hip fractures and BMD response to therapy. Here you see a trend, but not quite as strong, with non-vertebral fractures and BMD response to therapy. So there was a choice about whether total hip or lumbar spine BMD should be used as a better predictor of vertebral fractures. And it was found that BMD changes at all three regions of interest, whether it's the total hip, femoral neck, or lumbar spine, did indeed predict fracture risk reduction, but hip BMD changes explained a greater proportion of effect than lumbar spine. Also, we all know if we do bone density testing that lumbar spine is subject to more confounding factors than the hip, especially from degenerative changes in older patients. Total hip BMD precision is better than femoral neck, so there's advantages to using total hip over femoral neck. So for all of these reasons, total hip BMD was chosen as the preferred surrogate endpoint. So what if the FDA accepts a surrogate endpoint for clinical trials for approval of drugs? Well, then the FDA and other regulatory agencies around the world would have to determine whether preclinical efficacy and safety study requirements are retained, and that's what was proposed. They'd have to decide how large studies would have to be to approve a drug. And there'd have to be some sort of requirements for long-term safety with post-marketing evaluation of adverse events. If the FDA approves total hip BMD as a surrogate endpoint for osteoporosis trials, this would be the first surrogate endpoint biomarker that qualified under the 21st Century Cures Act in any therapeutic area. So this is very, very big stuff in the world of osteoporosis. And I think all of us are interested in opening up the drug pipeline and working on the development of new drugs for osteoporosis. So let's go back to clinical practice guidelines. This is what we have now with the idea of risk stratification and the implications. If you just focus on the bottom with very high fracture risk, both the Endocrine Society and ACE have examples of what might constitute very high risk. But the general concept here is that the greater the risk, the more aggressive therapy we should consider. So we think of very high risk when the bone density is very low, when there's been a recent fracture, when there's been multiple fractures, when FRAX is very high. These are the times when we should consider anabolic therapy. There's nothing wrong with a bisphosphonate or denosumab, but if you want to do the most for your patient, that might be with anabolic therapy first. So considering everything I've just explained, a new task force was reassembled, an international task force of experts to update the report of 2017 and develop a pragmatic approach to managing patients with osteoporosis. The task force members you see here, I think you'll recognize some of the names here. Some of those people are here in this room. It's been about a 2-year process of reviewing and assessing the data, many video conferences and emails numerous drafts and revisions. Submission to JBMR, more revisions. Finally, the manuscript was accepted and it was published online July 29th, 2024. That was Monday. So how's that for timing? So these are the major principles that were established. Treatment targets should be individualized with consideration of the indication for treatment, recency of fracture, number and site of prior fractures, severity of vertebral fractures, bone density, and other clinical risk factors. So a lot to think about. That's our job as healthcare professionals. Total hip BMD has emerged as the most useful treatment target because it consistently predicts vertebral and non-vertebral fracture risk reduction. How do we use this to select initial therapy? Well, we might consider treatment that has at least a 50% probability of attaining a treatment target over a reasonable period of time, which might be around 3 years in most cases, with greater urgency for patients at imminent risk for fracture. For patients at very high fracture risk, consider anabolic therapy first, followed by anti-resorptive therapy. This illustrates for you an analysis of data from FRAME and ARCH with romosozumab, looking at the probability of achieving a t-score that's greater than -2.5, which varies according to baseline t-score and the drug used. So here, as an example, if the baseline t-score is -2.7 or greater, then there's a 50% chance of reaching the treatment target of greater than -2.5 with any of these choices, with Romo followed by DMAB, Romo followed by alendronate, or alendronate alone. So no problem. You can use almost anything and do pretty well. But what if the baseline t-score is -3.0? Here, we have a 61% chance of achieving this target t-score with Romo followed by DMAB, but only a 9% chance with alendronate alone. So perhaps starting with alendronate is not such a good idea if you believe it's worthwhile to get up to a t-score of greater than -2.5. And analyses such as this could be done for other drugs from other studies, all of which might give us more information about how to choose initial therapy. So let's go through a few scenarios that were discussed in this paper. By the way, Felicia Cosman deserves an immense amount of thanks for all the work she did. This was a very large task force with a great diversity of opinions, and it required tremendous perseverance on the part of Felicia to get everybody together and compromise and finally come up with something that looks like it's going to work. So what if we're treating because the patient has a t-score -2.5 or below and no fracture? In that case, the minimum target should be greater than -2.5. After all, that's a treatment threshold in many clinical practice guidelines. But of course, more is better, and we need to consider the quality of the DEXA study that's being done and the least significant change. So you'd like it better than -2.5, but I think you also would want it to be more than the least significant change for the total hip at that particular facility. This is a major challenge because most DEXA facilities don't know their least significant change because they've never done precision assessment. So in this case, the initial treatment might be a bisphosphonate or denosumab for most patients. If the t-score is very low, even though they've never had a fracture, anabolic therapy might be considered as initial therapy. What if the indication for treatment is a prior fracture, but the fracture's remote, more than 2 years old? If the T-score is in the osteoporosis range and they've had a remote fracture, the minimum target would be a T-score greater than minus 2.5. Again, with this idea that more is better. Now, the initial treatment might depend in part on the type of previous fracture, because the risk of future fracture is somewhat dependent on the type of baseline fracture. So if the previous fracture has been in the spine, hip, or pelvis, consider anabolic first. If the initial fracture has been at another skeletal site, perhaps bisphosphonate or denosumab, or possibly anabolic if T-score is very low. If the T-score is greater than minus 2.5, but you're treating because they had a remote fracture, the minimum target would be an increase in total hip T-score of 0.2 T-score units, or about 3%, or a lumbar spine T-score increase of about 0.5% or 6%. And I'll tell you in a minute where those numbers came from. In this case, the initial treatment, if the prior fracture was in the spine, hip, or pelvis, might be anabolic. And if it's been other type of fracture, then bisphosphonate or denosumab might be perfectly appropriate. Now, to some extent, we can stratify fracture risk according to the type of initial fracture. So all fractures are not created the same. This is one of a number of studies showing that some fractures are greater predictors of future fracture than other fractures. So all of these fractures, even the lowly ankle fracture, are predictive of future fractures. But in our level of worrying about our patients, we probably ought to worry more about some types of fracture than others. So if a patient has a vertebral fracture, I think I'd worry more about future fractures than if they had an ankle fracture. Now, why did we come up with these numbers for T-score increase, like the 0.2 T-score units for total hip BMD? Well, looking at the data that we have, we know that a 1-year course of treatment with alendronate increases bone density at the hip by about 0.0 T-score units, or 2.9%, and the lumbar spine a little bit more. We know that 1 year of Romo increases total hip by 0.3 T-score units and lumbar spine by 0.9. Therefore, considering this range of effectiveness, it seems that these targets are easily achievable with a broad range of medications, both of which are proven to reduce the risk of vertebral fractures and non-vertebral fractures. Now, what if the patient is at imminent fracture risk? That is, they've had a recent fracture within the past 2 years, or multiple fractures, especially multiple major fractures, regardless of what the T-score is. So if a patient's had recent fracture or multiple fractures, they've got osteoporosis, they're at very high fracture risk, and you want to get them started on something. So the minimum target in this case, regardless of the T-score, is maximal rapid reduction of fracture risk. In the initial treatment, if the prior fractures have been spine, hip, or pelvis, should probably be anabolic first, with bisphosphonate or denosumab as a second choice. If they've had other types of fractures, you might think first about bisphosphonate or denosumab, but you can't go wrong with anabolic if you're able to get it covered. Now, we do have some situations where we're treating patients because of fracs, even though the T-score is better than minus 2.5, and they've had no fracture. In this case, it would be reasonable to consider initial therapy with an anti-resorptive agent with a minimum target of increasing total hip T-score by 0.2 T-score units, or lumbar spine by 0.5 T-score units. Now, monitoring is important, of course, with this. If the treatment target is not met, such as having a fracture on therapy, which of course nobody likes, this includes radiographic vertebral fractures. If they fail to reach a T-score target, or if they're not on a pathway to meet the T-score target, then we want to reevaluate the patient and correct, if correctable, any contributing factors. If they're on an antiresorptive, we might consider adding an anabolic, such as, combining denosumab and teriparatide, which has an additive effect, or switching to an anabolic. If they're on an anabolic, probably the best thing is to continue until you've completed the course of therapy with an anabolic, perhaps extending the duration of anabolic therapy if it's teriparatide they're on, or plan on repeating the anabolic course again, which we can do with teriparatide or with romosozumab. What if the target is met? Well, if a patient is on a bisphosphonate and you've met your treatment target, that's certainly the time to consider a pause in therapy. That's called a drug holiday. I always remind my patients it's not drug retirement. So holidays must end. The patients must be monitored. And if fracture risk is once again high, they need to have treatment resumed with a bisphosphonate or something else. If they're on denosumab and they've met their treatment target, it's perfectly reasonable to continue denosumab. There's no limit in duration of treatment with denosumab, or you could consider a transition to a bisphosphonate with all the complicating factors that you've heard about already. And if they're on an anabolic, I would complete the course of anabolic and then, as usual, transition to an antiresorptive agent. So to summarize, the goal of osteoporosis treatment is prevention of fractures. Response to treatment is not the same as having an acceptable level of fracture risk. Any treatment's better than none, as I've said, but some are better than others. Risk stratification and treat the target for osteoporosis. Focus treatment decisions on fracture risk in addition to having a response to therapy. And of course, as always, treatment decisions should be individualized. There's numerous variability in patient presentations that we all have. There's no one guideline or recommendation that's going to cover all situations. So we still need to think carefully, use shared decision-making, consider insurance coverage, and everything else we need to do in this country to try to get the patient on the best treatment we can. So thank you.
It looks like we have about 15 minutes, so people come up to the microphones for questions. We already have a handful online. Can you just go over again much of the literature you quoted in the paper that I'm going to read tonight when I can't go to sleep? It's uses total hip as the, why was total hip chosen over femoral neck and spine?
Well, total hip has better precision than femoral neck because it's a larger bone area, so that gives it an advantage there. It has an advantage over lumbar spine in that the total hip is a better predictor of non-vertebral fractures than is lumbar spine. And it's not subject to all the confounding factors with lumbar spine that happen, especially in older patients that have degenerative disease in the spine. So often I'll see a patient on treatment whose lumbar spine bone density goes up, and I have to decide whether I'm going to congratulate myself for allowing the patient to have such a great response to treatment, or whether I'm just going to think, well, that's osteoarthritis in the spine, and it's not my drug at all that made it increase. And frankly, in many cases, I don't know which one it is.
Okay, I think we'll give your name and where you're from to introduce yourself.
Hi, I'm Nicole Rothman, University of Colorado. Thanks, as always, for taking complicated things and making them really easy for us to understand. My question kind of actually dovetails off that. So I read DEXAs a couple days a week, and we report both hips. Sometimes one hip is up, sometimes one hip is not. I know some people report the total mean. I guess from a practical standpoint, if we're going to start to put so much weight into hip BMD, how should we think about that? And should we as DEXA readers be thinking about reporting it in such a way that this is going to be helpful?
I guess I can invoke the ISCD official positions on this, which aren't officially linked, but maybe they should be. So the ISCD says that we should make diagnostic classification based on a single hip rather than both hip mean values. For monitoring treatment, bilateral hip is perfectly fine. So I think it'd be appropriate if you chose to do it to monitor bilateral total hip and use those values. But for diagnostic classification, I would use the lowest T-score of the single hip, femoral neck or total hip, or the lumbar spine.
Thanks.
On the left.
Sean Baca, South Florida Rheumatology. The idea with treat to target becomes difficult when you've had patients on treatment for long periods of time. And specifically, I'm thinking of patients who are in DMAB and your results are not satisfactory. What I'm seeing here is that if you switch them to teriparatide, you're probably not going to go anywhere. And if you switch them to Romo, you might go somewhere. So is there ever a role for transitioning to something that will prevent the rebound effect, i.e. bisphosphonate, and then going to an anabolic? Or does it make more sense just to go right to Romo and just expect that you're not going to have a great result because you didn't have the opportunity to have these drugs prior, or they're just getting worse over time?
Yeah, well, first of all, I think we need to recognize that in some patients, a treatment target is not attainable. That's nothing new for any of us. I mean, we have treatment targets for hemoglobin A1C that may never be achieved, but we do the best we can. I think if you got a patient on Prolia and fracture risk is very high and you want to do something more aggressive, the transition I would make would be to go from that to romosozumab. If fracture risk was still very high, I might plan ahead of time to repeat another course of romosozumab. And in order for that to be most effective, I might treat them with a mild bisphosphonate, such as risedronate, after 1 year of romosozumab. Do that for 1 or 2 years, and then give another course of romosozumab. So I think the future of osteoporosis treatment is going to be to learn how to cycle drugs and how to sequence drugs better. And maybe in 5 or 10 years, we'll have new drugs that are more highly effective than the drugs we have. But that's the strategy I would take, I think, for a patient on denosumab who is suddenly recognized as being at higher fracture risk than what I initially thought. Does that make sense?
Yep. Thank you.
Bob Marcus.
Robert Marcus from, according to my tag, from Albuquerque, so I guess that's what I have to claim. First of all, Mike, that was such a lucid and thoughtful presentation of very complicated data, and it was just astonishingly good. I really appreciate that. I wanted to just address one small point and add some nuance because of the undisputable fact that initially with teriparatide, there is a reduction in hip BMD. It's a transient phenomenon, and I'm pleased to see that the extent over 2 years will accommodate that initial transient loss, and that made sense. Very few people actually here today were around doing osteoporosis when this phenomenon was first discovered, which was the paper by Bruce Ettinger following termination of alendronate. Going on to teriparatide, there was a transient loss of bone at the hip. So data done in animal studies and also looking at human biopsies showed that this loss reflected largely or almost exclusively an increase in cortical porosity, which was predictable given the fact, as John Bilizikian pointed out yesterday, that the anabolic response to PTH is exclusively due to remodeling transient. And so it's made up later on by overfilling the deficits. If the transient loss of bone due to increased porosity were of a major clinical impact, people should have seen in the Forteo trials or any teriparatide trials an increase in fractures at a time, because, as you say, a previous fracture puts you at imminent risk for a fracture, and you have several months of a reduced BMD. There should have been an increase in fracture, and there was not at all. And that's largely because the porosity seemed to be restricted out towards the cortical end and didn't really do very much to the biomechanical strength of the hip. So I just wanted to add a little nuance to the fact that the BMD does go down. This is not a clinically significant deterrence from using a teriparatide or any other parathyroid hormone in the treatment.
Thank you.
Right.
I agree. And you know, the treat to target report is classified as a position statement, not necessarily a guideline. And the nuances that you described and many others get back to that aphorism that I usually use, and that is that all guidelines are wrong, but some are useful. So this is a pragmatic position statement. I hope it helps some healthcare providers to do a better job. For many of us in this room, we would do absolutely fine managing our patients without the help of this, but I hope for some people it will help to advance the field.
So one online question, and I've had this one myself. If somebody gets an atypical femur fracture, for instance, somebody with breast cancer who's had lots of zoledronic acid, and when you do later on, when you do their fracs, is that a yes or a no on fracture? Yes, no. I mean, they have never had an osteoporosis related fracture, but they had an atypical femur fracture due to breast cancer treatment.
When you're doing fracs, does having an atypical femur fracture count as a prior fracture? I asked that question to two fraxologists, and I got different answers. I asked Professor John Canis, should I use AFF as previous fracture and fracs? And he said, yes. Then I went to Bill Leslie. I said, Bill, what do you think? Bill said, no. So take your choice.
Okay. Steve?
Stephen Petak, Houston, Texas. Amazing talk, Mike. That was incredible. I'll read the paper as soon as I can have a chance to. But I want to bring up, Lynn Kohlmeyer made a great analogy the other day about building things on a solid foundation. And as many of us are quite aware of, the ISCD criteria for bone densitometry certification and adherence isn't always adhered to. And being able to monitor patients properly by the total hip requires, first of all of the adherence to proper regions of interest, proper machines, same technologist. But more importantly, we always point out in our courses that especially on hologic machines where the lower line can be variable depending upon if the technologist knows what they're doing or not, that making sure the hip site is really adherent to the proper monitoring procedures and region of interest boundaries is absolutely essential. If you're putting more and more emphasis now on looking at the total hip, I think as part of what we do as clinicians is to ensure that our bone densitometry units are doing their job properly.
Yeah, you know, if everybody could, you could ask your local DEXA facility if they're ISCD trained and certified. You could ask them what their least significant change is. And if they say, what's LSE?
Yeah.
If they say, I've never heard of the ISCD, then maybe you should try to use another DEXA facility if there's a good one around.
Microphone on the right.
Thanks, Mike, for a great talk. Gina Woods, UC San Diego. I have two quick questions. One is, if we are going to be doing smaller studies and relying on post-marketing surveillance and reporting, what % of those adverse effects do you think will be reported? And can we make the reporting process easier for physicians who are already spending at least 50% of their time doing desktop medicine? And my second question is, do we do we need more drugs when more than 50% of people with osteoporosis are not on any of the ones that we currently have available? And should we be investing in better tools to deliver the care that we already have?
Well, you're right on both counts. Yeah, I mean, long-term safety monitoring is going to be even more important if the studies are shorter. So there's got to be better ways to do this. You know, if you mention an adverse effect that a patient of yours has had at this meeting, and there's a drug company representative here, they're going to contact you and tell you to report every little detail about that patient, even though maybe you can't even remember their name. So that's certainly a problem. Do we need more drugs? Well, yeah, the biggest problem, of course, is that most patients who are treated are not being treated. But I think we do need more drugs. There's limitations. For example, let me give you one example. You know, we're limited in what anabolic drugs can do. We only have an anabolic effect for 1 or 2 years, or maybe sometimes a little bit longer than that. What if we had a patient with very high risk, very low bone density, and we'd like to do more than that? What if we wanted to have a robust anabolic effect that lasted 3 years or 4 years that we could depend on? Well, why is it that we're limited to the anabolic effect with the current anabolic drugs we have? And it seems that there's counter-regulatory mechanisms that we have that cut that short. For example, if we're inhibiting sclerostin, maybe DKK1 starts to go up, and that counteracts the anabolic effect of our sclerostin inhibitor. Well, what if we had a drug that not only inhibited sclerostin, but inhibited DKK1 at the same time? Maybe we would get a more profound anabolic effect. Maybe there's other counter-regulatory mechanisms that could be addressed. And I think the basic bone scientists are doing fabulous work in these areas. And if we can open up the pipeline and take advantage of some of these advances, we might be able to do a lot more than what we do now.
Okay, I think we're gonna have a real short question. Ed.
Observation regarding tilting windmills at McLaughlin, rural Maryland. I've actually contacted personally the heads of radiology of all the hospitals within 90 miles of us to talk about how their performance values and densitometry, and have been told either personally or by letter that everything is fine, not to bother them. One of our hospitals currently is listed in the U.S. News World Report as a center of bone excellence. And from that particular center, 3 times now, we've gotten forearms upside down with T-scores in the -11 to -13 range. And so we called them and also wrote a letter to administration, basically told to buzz off. So that's where we are.
Okay, quick question. Then we're done.
Thank you for that comment.
Yeah.
Quick question. I don't have my computer with me. Probably at least one person in this room has pulled up that EPUB already, but I don't have access to it. So you reviewed what the main points are, but has the definition of high fracture risk and very high fracture risk changed versus, say, what was in the ACE guidelines?
No.
Oh, great. Thank you very much. Great presentation.
Good. Quick answer. Okay, I think we're going to move on to the next session.